here to support you, whatever.
Left over. I'm using it first because there's like two similar names.
What?
And then, but I'm sure I got the right one because it was.
Well, why don't we go ahead and get started? People can just settle in as they come in, and feel free to grab some refreshments, something to drink, something to eat. Feel free to get up and get stuff during the press conference. My name is Claudia Lenhoff, and I'm the Executive Director of the Champaign County Healthcare Consumers, and I wanted to thank everybody for coming out today, especially since the weather is not cooperating. Primarily today, Brooke Anderson and I will be talking about the medical debt report and presenting the information pertaining to that. We do have a consumer who has been affected by medical debt, and her name is Stephanie McAllister, and she'll be joining us a little bit later, and she'll also be talking about her situation. There are people here in the room who helped participate in this report, helped conduct interviews, or were participants in the interview process, and are people who have been affected by medical debt. So I wanted to thank and welcome everybody for being here. Just real quick, one of the first things that I wanted to do is make sure that everybody has a packet of information. And in your packets, you should have an agenda, which just tells you basically how, what we're going to be talking about. A copy of the media advisory that went out announcing this event. A copy of the press release that was put out by the Access Project. The Access Project is one of our national partners in this report, and they are releasing this report to national media today. If you are a media person, you've also got a contact list for some of the other partners so that you can contact them if you need to. And you also have a list of some consumers you can contact to talk to about their situation. Everybody should have a copy of the report, The Consequences of Medical Debt. Some of these have red covers on them, and others have the color cover, but they're the same report. So this is the national report that is being released today that we'll be talking about. You should also have a copy of a local supplement that we put together. And the local supplement is just to highlight more of the local issues pertaining to medical debt and the work that we're doing. And later on towards the end of this press conference, one of the things that we'll be doing is talking about policy recommendations and next steps, where to go, to address this problem. So we'll be talking about that later on, and that's specific to the local supplement. So everybody should have those materials. What I'd like to do now is just go ahead and give a little bit of background on the report. I want to talk about why we're doing this report, why it was decided that it needed to be done, why Healthcare Consumers was selected as one of the 3 local communities to participate in this, and then I want to just give you a quick tour of the report so that you'll know where to find things, and then I'll talk a little bit about how the research was actually conducted, and then Brooke will tell you about the findings. The first thing is that in terms of the purpose of this project, the Champaign County Healthcare Consumers for several years has been getting calls through our consumer health hotline from consumers who are having problems with medical bills and medical debt. And I would say over the past 3 to 4 years, we've seen that consumers are increasingly affected by more and more aggressive collection practices on the part of healthcare providers. And our sense was and has been that these collection practices have far-reaching implications beyond access to care. Access to care is an important aspect that we'll be talking about, but it seemed like we were hearing about fallout in consumers' financial lives in particular ways that were resulting from the medical debt. So we were interested in, we've always been interested in this issue and in looking into it, and we've also been interested in the, in the collection practices that seem to be more and more aggressive, more and more coercive. And basically it has seemed to us and other people who have been working on these issues that healthcare providers are enacting collection strategies that are based, it seems, primarily on bad faith assumptions about consumers. Bad faith assumptions that people aren't paying as much as they can, or that they are not willing to pay their debt, and so on, which is very contradictory to what we hear when we talk to consumers. And so the strategies to try to collect debt seem to be based on those bad faith assumptions. Those strategies hurt consumers. They also impair their long-term capacity to pay off future medical debt and current medical debt. And we believe that those strategies result in little, if any, financial gain for the healthcare providers themselves. So we really wanted to explore these issues. We wanted to try to start documenting how medical debt affects consumers, not just in terms of access to care, but how it plays out in their financial lives, and really try to start documenting that so that we can do a more systematic assessment of that beyond the anecdotal stories that we're hearing from consumers. We also wanted to try to start looking into how this situation affects the community, how it affects families, how it affects the community, and also what healthcare providers' perspective is on the situation, whether there is a cost-benefit to them for doing this, or whether these are just sort of practices that have been enacted perhaps without much thought for or awareness of how it's really hurting consumers, or what it brings back to the healthcare providers. So the purpose of this research was to really start getting a handle on the nature of medical debt, how it affects consumers and families' financial lives and healthcare access, and how it also affects the community as a whole. Healthcare Consumers was selected because we have been in the national forefront, believe it or not. We know it because we get to go and talk to national groups and so on, but we have been in the national forefront talking about medical debt, about medical billing practices, problems with medical bills, problems with collection practices. We were among the first to start talking about the increasingly aggressive and coercive strategies that healthcare providers are using. And so we have a long track record of working on these issues, and that's why the national partners, the Access Project and Brandeis University, turn to the healthcare consumers to help with this. We also have an organized medical billing task force that has a lot of experience, consumer involvement, and has been around for a few years, so we had a good basis in the community to try to do this work. Okay, what I'd like to do now, and there's information in the local supplement along these lines, why we were selected and so on. What I'd like to do now is just take you on a quick tour of the report. So everybody should have a copy of the report. It either has a red cover or a color cover like this. In the front of the report, you'll see descriptions of all the different partners who participated in this. There are essentially 5 organizations, 3 local community groups, Healthcare Consumers, and then the Human Services Coalition of Dade County, Florida, and then the Tenants and Workers Support Committee in Alexandria, Virginia. There's a pretty comprehensive executive summary at the front of the report on pages 1 through 3, and then there's a section, an introductory section and background. And part of the methodology for conducting this research was that we did consumer interviews, but also researchers from Brandeis University came to this community and to the other 2 communities, and they actually tried to interview healthcare providers in every community. They tried to interview social service providers, including credit counseling agencies, service providers that deal with housing and other issues, any kind of service provider that may end up working with clients who are affected by medical debt or whose credit has been affected by medical debt. And the purpose of interviewing those folks was to try to get a sense of the scope of the problem. How many people are affected by this medical debt issue? How widespread is it? And what is the impact of it? So the first section in the report, starting on page 7, talks about the organizational interviews. And Brooke will go through the findings. The next section, beginning on page 12, talks about the consumer survey, and it goes through the findings. Every community that participated in this, the 3 communities that participated in this, each interviewed about 30 consumers to try to ask questions about medical debt and how it's impacting them in terms of access to health care and their financial lives. Those consumer interviews were developed partially in this community through the work of the Medical Billing Task Force. And I won't spend too much time on that, but I will say that that was a pretty intensive process of really trying to figure out the right things to ask about to really try to get at the effects of medical debt on consumers' financial lives. A lot of times people's credit is affected and they have a hard time getting housing or whatever, but they don't necessarily call us and say, I can't get housing because my credit was affected because of a medical debt. You know, we kind of uncover that, so we wanted to ask directly about those kinds of things. So that's actually the bulk of the report. And then beginning on page 24, there are tables that show that represent the data graphically and the findings that are described in the study itself. And then the last section is what I just sort of described to you. It's a methodology section explaining how the study was conducted. So if you want to learn more about that, you can turn to the back of the report. So that's your quick tour of the report. I've already talked a little bit about the methodology. Healthcare consumer staff members and volunteers, advocates from the hotline, members of the Medical Billing Task Force, all volunteered to meet and work with consumers to conduct the surveys. And then we collected that information and sent it to Brandeis, and that's where the consumer portion of the information comes from. Healthcare consumers, in addition, did other research that the other communities were not able to do, where we looked at bankruptcy filings and small claims court cases and things like that, so you'll find that in here as well. The service providers interviews, the one thing that I will tell you is that in our community, we were the only community where the healthcare providers, and we're talking about major healthcare providers, refused to be interviewed for this survey. In the other two communities, they did agree to be interviewed, but in this community, they did not. Okay, the last thing that I want to tell you before turning it over to Brooke to talk about the findings is I just want to tell you a little bit about who responded to the survey, who the sample is. And you can actually see this on page 12 of your report. 2/3 of the sample, so this is across all three communities, are women, mainly between the ages of 30 and 49, representing households with 2 or fewer children. More than 2/3 reported that they currently had no health coverage, and 3/4 were without coverage sometime during the past year. One of the issues that we're looking into is the fact that nowadays, because of the economy and the cost of health care and the employment market and so on, that people are insecurely insured. They may go in and out of having insurance or being uninsured. Both groups, insured and uninsured, had comparable levels of medical debt, and over half the respondents indicated that they are currently unemployed, and half said that they were unemployed when they started owing money for medical bills. So that's who we were talking to. And I guess at this point I will just go ahead and turn it over to Brooke Anderson, who will tell you the findings of the report.
Okay. I've sort of 3 parts to this. First, I'm going to try to give you a framework for understanding medical debt, and then I'll talk about the findings of the national report, the key findings, and then give you, try to pull out and lift out from the report the findings that were particular to our county and consumers, the experiences that consumers have here in Champaign County. So starting with the background information and the framework for understanding medical debt, it's important for us to challenge some of the assumptions that come up from the providers about medical debt, and to let you know why it's a problem and for whom it's a problem. The first thing to know is that healthcare, healthcare is not like any other business. The people who seek healthcare are in a vulnerable financial and health situation by virtue of the medical care for which they're seeking the healthcare provider's services. And the product that the healthcare business is selling is a product unlike any other. It's often life-saving or life-sustaining. It's something that people simply cannot do without. And those, quote-unquote healthcare purchases are often different from other services in that they're often unplanned. It's not something that people save up for years to be able to do at the exact right time. And they also result in large financial burdens for consumers. And so, in other words, it's an involuntary choice. It's different than other traditional health or other traditional consumer choices. So we're not talking about expensive jewelry or furniture or cruises. We're talking about a mother taking her son to the emergency room because he stopped breathing, or we're talking about a cancer treatment for your elderly mother. Things that people simply would not choose to go without. And this is not to say that healthcare services should not be compensated. That's not at all what we're suggesting here. Of course the hospitals, the clinics should be compensated, but rather the situation of the consumers who are seeking care and their vulnerable position financially and health-wise suggests that there ought to be some more flexibility and accommodation to individual circumstances and ability to pay. And that the healthcare providers ought to be more willing to negotiate payment arrangements with consumers. As I said, these are unexpected, unplanned medical services, and this is affecting people who do and don't have insurance. Lots of times in the national debate we're seeing it's all about who does and doesn't have health insurance, and what we're finding is that even people who do have health insurance are incurring great costs for the health care that they're seeking. Something else to know is that hospitals charge their highest prices to the people who are very least able to pay, the people without insurance, the hospitals and the clinics. And the average hospital, and the reason this is because the average hospital will discount up to 50%, even sometimes as high as 70%, to insurance providers. And so that means if you have insurance, you're going in and they're charging the insurance company and then you for your copay at a huge discount. But the people who don't have insurance, who are also folks who are least able to pay for those healthcare services, are paying 2 or 3 times as much for the health care. And this is something that's referred to as discriminatory pricing, which you'll probably hear a lot more about in local and state legislative debate in the months to come. The next thing to know is that consumers are working hard to pay their medical debt. I think oftentimes when you look at the policies of the providers, it makes an assumption that they're lazy or that they don't want to pay for the services that they have. But consumers, we found almost unanimously throughout our surveys, they want to pay their bills. They're working hard to pay them. And oftentimes they're even jeopardizing money that they need to meet other basic life necessities like housing or transportation or food or prescriptions in order to try to meet the sometimes unreasonably high payment demands of the healthcare providers. And the other thing to know is that the providers aren't negotiating these on a case-by-case basis. They're not sitting down with the individual and saying, okay, how much money do you have? How much could you pay while still meeting your other life necessities? And we found that more than half of the people that we interviewed had tried to work out a payment plan with the healthcare provider. And of those who tried working out that plan, many were not able to maintain that plan over the months. And the main reason for that is because the healthcare provider demanded too high of a monthly payment and was not willing to be flexible when people had other situations or circumstances that would mitigate their ability to pay, for instance, a second health crisis or lose their job or whatnot. The next thing to know is that paying off your medical debt, even with a high monthly plan, isn't protection from collections, from lawsuits, or from denial of care. So the consumers that we talked to who were making payments toward medical debt did not see any significant difference in whether or not they were denied access to care, or whether or not they were asked to pay cash up front from the healthcare providers. So even people who were making payments, and even at the rate that maybe they had said that they could, these folks are still getting sued, their credit is still getting ruined, and they're still being taken to collections, even if they every single month putting some money toward the bill that they owe. And the other thing to know is that the healthcare provider is getting money from the insurance company at the same time that they're pushing for more and more money from the patients. So they are receiving money. One of the things that we found that was shocking is that people's lives are being ruined for relatively small amounts of money. So a lot of consumers that we talked to had been taken to court and sued for as little as $100. Which may not sound like a lot, but to someone whose only income is Social Security or veterans benefits or who has had a major health crisis, that's a lot of money. And most owed under $5,000, but even when it was this small, if the providers were demanding too much too fast, this became overwhelming and they ended up in court. Lots of people ended up with bad credit because their medical debt was reported to the credit agencies, and this made it hard for them to get loans, to buy homes, to be able to rent apartments, to purchase cars, and sometimes even to get a job now that a lot of employers are looking to credit checks before they hire someone. And a lot of these folks ended up in bankruptcy as a way to try to relieve the constant harassment from the collection agencies and get sort of a fresh economic start. And a lot of the folks that we talked to who had medical debt were the very same people who ought to have received more assistance and services either from the healthcare provider or from the public. So a lot of folks were low-income folks or older folks on Social Security. A lot of these folks are people who came to us through other social service agencies. For instance, the homeless shelters, or through the township, through the Urban League, women's shelters, rent and heat assistance programs, age shelters. And a lot of these consumers reported to us, or these social service agencies reported to us, that people were being asked to pay so much, or the collection agencies would say to someone in a senior program who said they couldn't pay, well, do you have any clothes? Well, then why don't you sell your clothes to get money to pay back the healthcare provider? So a lot of these folks are people who are using services who are otherwise ought to be getting assistance, and the healthcare providers knew that they were in this situation and nevertheless pursued to collect that medical debt. And a lot of these folks are actually what is called judgment proof. So patients who go in and owe medical debt but who are, for instance, on TANF or veterans benefits or disability, or whose only income is Social Security, their income and assets are what's called exempt from collections. That means that legally, if their income falls under, I think it's $230 a week after taxes, they do not legally have to pay any money so long as their income is under that level. This is why, but a lot of people don't know their rights and don't know that they're legally exempt, and this is why we went to the courthouses to pass out brochures to let people know about their rights. And one of the things is that the ACA International, which is a trade association of collectors, found that only about 7% of the medical debt that healthcare providers go after in collection is ever recovered. So we're looking at a really tiny fraction of the overall debt that they take people to collections for is ever recovered. And this really shows a failure on the part of the providers to adequately discriminate who can and cannot be able to pay at the rates that they're demanding. And I think this is clearly an example of a situation where no one is benefiting. The providers are facing state budget cuts. They're struggling financially, but at the same time it seems like they're wasting precious financial resources either internally or when they choose to outsource their debt, trying to get payment from people who cannot pay at that amount and who would actually be able to pay off their total debt eventually if they had a reasonable payment plan. And so this results in a downward spiral for many individuals and patients with medical debt. Oftentimes they've lost their work, or they've lost wages, or because of the health crisis they can't go back to work. Many of them, because they're denied access to care in the hospitals and the clinic, end up using emergency room services because they can't be denied for those. And of course, the emergency room is the most expensive place to seek care, both for the consumer and for the community who subsidizes the use of that emergency room. And because people are afraid to go to the hospital and incur more debt, oftentimes their health situation worsens, where once they could have gone in for a regular visit and gotten the medication that they needed, the checkup that caught, or the screening that caught this or that disease and gotten treatment, they don't go because they're afraid they'll be harassed, or they're asked to pay cash up front, and all of a sudden they end up with the worst healthcare situation. And this is not just impacting individuals, but also families and friends and social service providers, the entire community, because a lot of people are borrowing money from friends and family to try and pay off that debt, or the social service agencies are trying to give them assistance to be able to pay off that debt, or have to house them longer, provide them assistance longer, because it's harder for folks with medical debt to become self-sufficient if their bad credit as a result of medical debt makes it harder for them to get that car that would allow them to go get that job or get their own home. I think the next thing you should know is that it's also damaging the healthcare provider's reputation in the community. A lot of the consumers that we talked to said that they were made to feel like third and fourth class citizens, and they really felt like the hospital was being greedy and asking them to pay off their medical debt before needing basic living expenses like food and rent. So that's sort of the background about what's happening with medical debt. And then the key findings is some of the same things, that health insurance doesn't always protect individuals. We found that individuals are really struggling with understanding their medical bills, and this isn't their fault. They bring their bills in and show us, and they're very confusing to us as folks who have a lot of experience looking at these bills. Sometimes it's not clear who they owe on the medical bills. It's not clear how much they owe. Sometimes they make payments and the overall balance doesn't go down, and they found out later that that's simply because they're only paying off the interest every month. They never see their balance go down. Sometimes they're charged twice for the same service. Sometimes they have what's called upcoding, which means that they're charged for a more complicated procedure than what they've had done. Sometimes they have bills resurrected from years and years past. So they're very confusing medical bills. When folks are not complying with the treatment simply because once they see these bills, they're afraid that any more healthcare services that they seek will require more bills. We also found that the collection agencies are becoming more and more aggressive in their collection. So where once they might wait 120 or 150 days before turning bills over to a collection agency, all of a sudden it's 30 or 60 days. So 2 months and you don't pay, and all of a sudden you find yourself in small claims court being sued. And once people are sued, and if that doesn't bring relief, then lots of folks are filing for personal bankruptcy as a way to get away from the everyday phone calls from the collection agency and the harassment that they get on the job when the collection agency comes to visit them. And so this is one form of relief. People are also being deterred from seeking jobs because of medical debt, because maybe they've had their wages garnished in the past, or the collection agency has shown up at their work. And it's also creating a lot of stress and anxiety and feelings of hopelessness. People feel embarrassed and shamed about medical debt when they shouldn't. But the hospitals are making them feel that way by bringing them before their billing offices, or requiring that they pay cash up front, or sending them nasty letters. So people feel like they're being financially punished for an involuntary purchase that they've had to make, which is their health care. Specific to Champaign County, some of the things that we found that were unique to this community is that Champaign County healthcare providers were more likely to deny care to people who had medical bills, or to demand cash payment up front for medical services than either of the other two communities that we're surveying. Champaign County providers were also more likely to delay care because people had medical bills and not schedule them appointments as soon. And Champaign County were consumers experienced more times where they were asked to pay cash up front than the other two communities in Virginia and in Florida. Looking at local bankruptcy data, we found that in the year of 2001, there were 279 bankruptcy cases during the month of December 2001, and that there were what would be approximately 3,200 for that entire year. And of all of these bankruptcies in 2001, we found that 58% of those bankruptcy cases involve some kind of medical debt. And this is important because the national average of the percentage of medical debt within bankruptcy cases is only 40%. So in Champaign County, we're seeing almost 20% higher incidence of medical debt among bankruptcy cases. And this past year has been the highest ever bankruptcy rate in the history of the United States, not by virtue of medical debt, but overall bankruptcy we're seeing increasing. And then within small claims, between May and December of that year in 2001, an average of 7 people per week were directly sued by healthcare providers in Champaign County in the small claims courts. And this is probably actually an underestimation of the situation, because these cases don't include the debt that people owe to their friends and to their families. It doesn't include the bank loans that they took out to try to pay for this. It doesn't include the debt that is on their credit cards when the healthcare provider pushed them into using a credit card to pay off that debt. And 20% of these small claims cases were brought by nonprofit hospitals. And this is particularly egregious from our perspective because a lot of these hospitals have a mission to serve the poor, serve the underserved, and instead they're pushing people into financial devastation and exacerbating the health crises for which they went into the hospital in the first place. And many of the folks that we had interviewed brought this up in their interview. They didn't understand. They thought that the hospital was a place that was supposed to take them no matter what, and all of a sudden they were being denied, or they were staying in a local homeless shelter and they couldn't even get in, and the hospital has turned them over to a collection agency that would harass them. And the patients who are being sued, a lot of them, again, had balances as little of $100. When we look at that data, that only 7% of the medical debt collections are ever recovered, and it's for money so little, but it's causing people all this stress and anxiety and feelings of hopelessness over this little money. It's really hard to understand who gains from these practices.
Thank you. There are hard data in the report in terms of actual numbers, if people want to look at that. One thing that I wanted to point out is actually on page 13, where it talks about what people owe and to whom. And this underscores the point that, that Brooke was saying about that this debt is involuntary. It's usually a result of an injury or illness, you know, that has to be dealt with. Most respondents, who we talked to associated their medical debt with a hospital visit. Almost 2/3 attribute the hospital expense to emergency room visits. And many also reported owing a primary care provider, because a lot of times when you're in the hospital you end up with more than one bill, and you will have to owe a physician, or they may have had primary care services as well. And again, as Brooke said, almost 20% of respondents in this survey owed less than $1,000. So the financial ruin that people are experiencing, a large number of those people actually have relatively low debts, but it's because of the demand for high payments in a relatively short period of time that $1,000 can break a family financially and can lead to ruining of credit and so on. Almost 40% of the respondents owed less than $5,000. And just to help put this in perspective, before I get into the policy recommendations, you might wonder, how do you end up with a $5,000 debt, for something? And if you just think of an event, maybe a one-time sort of event, like you have to have a gallbladder surgery or an appendectomy, or something like that, which many of us have probably had, the range and price for something like that, if it's relatively uncomplicated, could be anywhere from, $4,000 to $12,000, depending on who's paying for it and therefore what price they're being charged, and how much hospitalization is required. But that's just an example of how you can incur a debt in several $1,000s for a relatively simple situation like that. Okay, so I want to just go into policy recommendations next before we open it up to questions, and hopefully Stephanie will be able to join us soon. She actually had is she here?
She's coming back before check.
Okay, she had a medical appointment, so that's why she was coming in late. I just wanted to talk about some policy recommendations. You can actually find them beginning on page 7 of your supplement, the local supplement. And I want to say up front that this isn't a definitive list of policy recommendations of everything that has to be changed. We need to go actually through a community process of talking to consumers and social service agencies and the healthcare providers and others to develop, a more extensive list. But these policy recommendations, as preliminary recommendations, come from the Medical Billing Task Force, and we wanted to talk about things that healthcare providers can do immediately. They could start doing today to start addressing this problem, to stop the financial ruin of families and individuals because of medical debt. Because remember, part of this problem, a huge part of this problem, is not just the fact that people owe money. It's the fact of how that debt is being collected and the aggressive and coercive practices. So one of the first recommendations that we have is to cease the practice of using denial of treatment or denying access to care to people because of outstanding debt. We think, obviously, this will benefit consumers. Consumers need health care when they need it. We think it will benefit the healthcare providers because if people get timely and necessary treatment, they'll be healthier, they'll be more able to function and to work and to be self-sufficient and to manage their debt and things like that. Also from a public health perspective and a public good perspective, it doesn't make sense to be creating medically underserved populations. Our other recommendation is that healthcare providers should work with consumers to make reasonable payment agreements that are affordable to the consumer and that are realistic. Right now, a lot of times healthcare providers say that they have health plans, and again, I'm talking about the major healthcare providers. They say that they have health payment plans, but a lot of times what they're talking about is the debt, regardless of the injury or illness that led to it and the person's financial circumstances, they're asking for repayment of that debt in 10 payments. So if somebody has a $5,000 debt, they might be offered a payment plan of $500, and the person perhaps can only afford $20 or $30 a month. So there needs to be a more flexible and realistic arrangement to work with consumers, because as we've stated, consumers do want to and do try to repay their debt. Do not report medical debt to credit bureaus. We just see no reason whatsoever for doing this, and it causes such tremendous harm to people in terms of their capacity to qualify for loans, housing, jobs, things like that. We have seen nothing that indicates that this in any way benefits healthcare providers or that it works as a deterrent, for people to paying their or for people to, be paying their bills or not paying their bills. It just seems to be something that ought to be off limits. Credit should not be ruined because of medical debt. We also feel that healthcare providers and the collection agencies with whom they contract should not be coercing or pressuring patients to pay their medical debt with credit cards or by taking out loans. If a consumer wants to do that and they feel that that's a viable option for them that will not harm them financially, that should be their option. But it shouldn't be a pressure that is put upon them, because that simply just deepens people's debt. Healthcare providers will ultimately benefit, again, from working out better and more realistic payment agreements with the people. Credit card debt is a major factor contributing to bankruptcies, and we think that medical debt paid off through credit card debt is part of that problem. We think that healthcare providers need to make their financial and collections policies public. Patients in the community have a right to know what the financial relationship is, what the consequences are, what is going to be done to collect that debt, and patients in the community can have a better understanding of the policies, and therefore they can have better information with which to plan for how to deal with their medical debt. We think it would protect healthcare providers from the public perception, which currently exists, that they are capricious, punishing, and vindictive in their approach to collecting medical debt from their patients. We think that healthcare providers need to make a commitment and also need to assure a commitment on the part of the collectors with whom they contract to treat people with dignity and respect. This report documents very clearly how mistreatment and people being made to feel ashamed because of their medical debt or being treated with attitudes as if the patient is acting in bad faith with regard to their medical debt prevents people from utilizing the healthcare system, getting the healthcare that they need, managing their health, and also establishing a relationship with the healthcare provider where they can actually work out a reasonable payment agreement if possible. It's no excuse for a healthcare provider to contract with a collection agency that mistreats people. From a consumer perspective, and certainly from our perspective, we feel that healthcare providers are responsible for the behavior of the collection agencies with whom they contract to try to collect their debt. A collection agency that tells a low-income senior that she needs to sell her clothing in order to make a $20 payment 1 month when that low-income senior is on Social Security only, that is an abhorrent practice, and it is not just the responsibility of the collection agency. We feel it is the responsibility of the healthcare provider to not allow that kind of behavior. The Medical Billing Task Force and the Community Health Partnerships Access to Care Work Group are joining together to conduct a survey of healthcare providers' financial policies. Again, we really feel that healthcare providers need to make their policies public so that we can begin a dialogue and work towards meaningful and helpful policy change. And in order to help get that process started, the Access to Care Work Group and the Medical Billing Task Force will, beginning next week, be asking healthcare providers to complete a survey of their financial policies. This survey asks about all kinds of questions about how they make determinations about which accounts to send into collections, what is the time frame for doing that, are there minimum payment amounts, how do they work out payment agreements, do they report to credit, will they serve people who have filed for bankruptcy, and all kinds of questions like that. The Medical Billing Task Force and the Community Health Partnerships Access to Care Work Group will also be soliciting input from consumers in the community to develop additional policy recommendations regarding medical debt. Again, we're not presuming to have the answer. The policies we're recommending today are things that can be enacted today that will have immediate relief and benefit to the community, and so that's why we're starting there, but we realize that there will need to be more work in the future. And lastly, I think we can also look at policy issues around local ordinances, around state and national legislation as well. And just one example of that, actually there's a hearing going on today in Springfield over Senate Bill 552, which is, as amended, which is the Discriminatory Pricing Reform Act. This is something that we support. This Discriminatory Pricing Reform Act prohibits hospitals from charging uninsured and medically needy patients inflated prices for medically necessary hospital services. So this legislation would deal with the issue of discriminatory pricing, which contributes to medical debt among uninsured people. And those are the recommendations. Is Stephanie here? Okay. Why don't we go ahead and open up to questions and answers and hear what people have to say, or people who had their own experiences that they want to talk about.
High interest rates on medical debts a problem for consumers?
Yes.
Do you know what the charges are, percentage-wise?
In our community, there are, I think the typical finance charge on medical bills is about 18% annual. And that is a problem. As Brooke said, a lot of people who are trying to pay off their bill get very discouraged when they see their monthly payments not having any effect on the balance because it's not going down. Healthcare providers have different practices around that. Some of them don't initiate the finance charges until after a certain point in time. Some of them used to have them but would verbally let patients know that once they've paid off their bill, if they had set up a regular payment plan, if they stuck to it and they paid off that bill, then at the end the finance charges would be waived. But I don't know if that's happening anymore, that kind of arrangement, but it is more and more common to start putting finance charges on there. And one of the problems with that, just to be clear, is for people who do have insurance, if it's not Medicaid, for example, it can be Medicare or it can be some other, it can be private insurance. If the insurance filing and payment isn't processed in a timely way, but the billing mechanism moves ahead, people can actually be getting charged interest on medical debt that should be getting paid by the insurance company, and a lot of times the consumer ends up carrying the weight of that finance charge. Other questions?
Do you have any feel for why you could not get response from the major medical providers in the community?
I think, well, a couple flat out refused, and then there were, and I think one of the things to sort of be clear about is this wasn't healthcare consumers coming and saying we want to talk to you all. There were partners in this project. This was Brandeis University that was approaching these healthcare providers. A couple of the other ones said, you know, we'll see, but then when it came down to it, they weren't willing to schedule it. And the researchers, Jeff Protas from Brandeis University, their impression was that in general, across all communities, healthcare providers are very reluctant to sort of open up this aspect of their operation, you know, to examination. But as I said, in the other two communities, they did go ahead and meet with them. In this community, they refused, but there seems to be a general, you know, reluctance to do this. And my hope would be that the healthcare providers will find this compelling and will realize that, you know, this is a problem that we can all work on together, and where all segments of the community involved can potentially benefit from this. Because I think the practices that they're doing right now don't seem to be resulting in a financial benefit to them. But I think they're just really reluctant to, you know, to open that up and to look at that. And our community, our healthcare providers, are a little bit different than the ones in the other two communities. For example, as Brooke talked about, they are much more likely to use the strategy of denying access to care to people because of outstanding medical debt. They are much more likely to demand payment up front from people who are carrying medical debt in order to give them an appointment. So they just seem to be a little different than the other ones. A little meaner sometimes, actually, people feel. Other questions? See you, Mr. Hayes. Well, thank you all very much. We'll just sort of stick around and be available to talk to people or to answer questions. And thank you very much for coming. The one thing that I'll let you know, we're not sure exactly of the date, but probably in early April we'll be having a town meeting about these issues. Bob Seifert from the Access Project, who's one of the primary organizers of this report, will be coming here to this community, and will be providing a little more in-depth information about what's happening in Champaign County compared to the other communities, so that we can start working more on our policy recommendations. Thank you. Howdy. Sure. Do you want a chair? Do you want to sit in the middle? Yes, we both worked on developing